Hello everyone, welcome to UKRD Annual Summit 2021. For those of you who don't know me, my name is Nav Ahulwalia. I'm a medical director and a director of research for a mental health community trust in the north of England called Ardash. And it's my great pleasure this morning to be in conversation with Professor Lucy Chappell. Professor Chappell is a professor of obstetrics at King's College London. She wears a number of very big hats. On top of that one, she is the Chief Scientific Advisor to the Department of Health and Social Care, and because of that role, she's also the person who directs the work of the National Institute for Health Research. So Lucy, thank you so much for making the time for us this morning. I know that you must be incredibly busy, so thank you very much.
Thank you very much for the invitation to come and talk to this group, a group who are really important in the research ecosystem.
Thanks, Lucy. So I suppose we'll start by just discussing your journey, really. We've all got a journey. What was your journey to get you to the current positions that you hold that I outlined earlier?
Well, thank you for that introduction. And in terms of setting out what it is, so I'm, as you mentioned, I'm Chief Scientific Advisor, and that's an interesting role. There's just to sort of set out what that looks like. I'm one of around 20 Chief Scientific Advisors, one in each government department, and then overseen by Sir Patrick Vallance, who is the government CSA. And as you say, with it comes Chief Executive of the NIHR. So my journey to those roles are as a clinician researcher. As you mentioned, I'm a professor of obstetrics, and I've got a track record in pregnancy research, particularly around pregnancy hypertension. And I've done a good number of different sorts of studies, both from the sort of earlier phase work through to implementation, mainly clinical trials along the way. And I'm also a consultant obstetrician. I work at King's College London for my academic work and Guy's and St Thomas's as a consultant obstetrician. And I've maintained both of those at a 20% role, because for me it's important about being close to the ground. And so I am currently familiar with opening multi-centre studies and very grateful for all the work that the UKRD community do, because I'm still up close and personal to it. So my career journey has sort of followed that and has now brought me to this place to take on these bigger roles of CSA and Chief Executive of NIHR.
Thanks. So if I've heard you right, Lucy, we've got clinical background, academic research background, and now national leadership roles as well. But at the same time, as you've been on that journey, you've managed to maintain links with all three of those now, so you don't lose touch with the front line as well. So thanks for that. I think because of what's going on with COVID, we can understand how your Chief Scientific Advisor role is of relevance. But could you describe how that links in with NIHR?
Yes, and I think I think that's a very good question, because I think there isn't necessarily a clear understanding. So NIHR is the sort of funder arm of the Department of Health and Social Care, and in fact across government departments we have one of, as a CSA, I hold one of the biggest research budgets of a government department, and that's because for me and for the community, it is crucially important to us that science and research and evidence underpins the government policy. And this is our opportunity to really ensure that we generate the evidence so that what we do in health and social care is underpinned by that evidence. And there is very close working between particularly those in Louise Wood's directorate, the Science Research and Evidence Directorate, and the rest of the Department of Health and Social Care to see that. I work with the other civil servants across the department to try and strengthen those links. NIHR is the way that we enact that. It's the incredible vehicle through which we make research happen in this country. And Sally Davis did this amazing job of setting it up, ensuring that it's sat really integrated into the NHS and now has delivered so massively through the pandemic and also so much before the pandemic.
So Lucy, we were spending a lot of time there talking about social care and social care research, and I have to admit that I wasn't expecting you to spend so much time thinking about that. It's a real priority for me in the field I work in, and I know for many of my colleagues. I think people from UKRD will be really keen on knowing more about that one in the future. But given what you've said about health and social care, if we could just turn our attention now to the health priorities and health research. What do you think of the health research priorities over the next decade?
Well, I do see them as interwoven, and I think that the more we see them in that way is positive. But I think my response really covers both, and they go back to my focus on health inequalities through using the Best Research for Best Health, which was the document that came out in July of this year, focusing on 7 strategic focuses. And the reason I've sort of chosen to adopt that is I had sight of it before it came out, and I came into post shortly afterwards. But it's very well structured to look at what we need to think about as a community. So those 7 areas, we're thinking about the recovery of the health and social care research system, which is very relevant to the UKRD in terms of how they play this really crucial role in that recovery, and have really shouldered a lot of the burden of keeping research going, both COVID and much other research, and that's across the UKRD work. The next one being around capacity and capability in preventative health, public health and social care research. And again, that's I'm really interested in understanding how I work with the UKRD community to go into areas that are a bit new, but really building on what we've done before in that, and thinking again about sort of adapting our ways of working for those areas. The third one is about how we tackle the lives, improving the lives of people with multiple long-term conditions, and asking all researchers in this area to take an inclusive approach to this, and to say that those are real people with and they're us, and to think about how we ensure that our research is inclusive. We've got a particular focus on bringing research to underserved regions and those with major health needs. And given the reach of UKRD, this is so important to ensuring that, again, research is for everyone, not just you. And there's many ways that UKRD can help because of representation across every area. And this is NHS Trust, but it's also thinking more widely about primary care, community care, and even into sort of local authorities, and really serves to think about how we tackle those health inequalities. EDI is important to us across NIHR, and again should be relevant both to the researcher workforce and the participants in a virtuous circle, so that we tackle both, and that we know if we have a representative workforce that fully embraces ED&I principles, that will also be reflected in our participants and vice versa. We're really clear that we want to strengthen careers, not just for the pathways that we have well embedded, such as the academic pathways, but also for those across the research delivery system. And that might be those from other healthcare professionals, social care research professionals, but also really talking to UKRD about where the research professional development opportunities are, and understanding from the community themselves what that would look like. And the last one is working with the life sciences industry. UKRD's got a track record in this already, in facilitating it, understanding how that is done transparently, but also in ensuring that we have a joined up approach from the health and social care research sector and the life sciences industry to make sure that's coherent from all perspectives.
Thank you for that summary, Lucy. I think, although I'm sure many of the community will have read that document, I don't think they will have perhaps had it so neatly summarised in terms of the priorities. Although later on I was going to be asking you a bit about levelling up, given that you've talked about health inequality so eloquently, and it's a major part of what you believe in, as well as the priorities for research nationally, do you think NIHR has a role in that national levelling up agenda? I don't mean the political agenda necessarily, but in terms of areas of need, whether it's coastal towns, rural communities, old steel towns. What's your view of that?
It's got more than a role. It should be a leader, and I think it is very well placed as not just the leading health research funder, but also in leading from the front on this. because it is so deeply relevant to the mission of the NIHR to improve the health and wealth, not just for a select few. So I think you absolutely name it, that levelling up needs to consider all the different lenses, whether it's socio-demographic, geographic, but it's certainly been made, the point's been made very strongly that geographic might be coastal communities, as you say, and highlighted in the CMO's annual report this year, that you may get areas of quite marked deprivation next to areas of wealth, such that the average looks okay, but the reality on the ground isn't. So this is asking all of us to think about how we get research to those, both the underserved regions, but also the people with the highest health needs. This is about inclusion, not exclusion. And it's got something relevant both for those, for example, in London. They are an inner city hospital in London is research experienced, but may well be serving a population of very mixed deprivation, so that they can reach those who are less represented in research more clearly. And it also talks to those who are newer to research. Now, we know that some of the trusts that are newer to research did amazingly in the COVID pandemic and has brought it home to their trusts that research is part of business as usual within clinical care. And we've seen some of those those trusts fly and really to see what is possible. We've also seen it, for example, we've placed the translational research centres that work with industry in outside the so-called Golden Triangle to really focus research again on areas where it is needed. My experience as an investigator and in this role is that trusts who are newer to research that may well have an energy that we really welcome and can be harnessed. So I think in areas of high disease burden, sometimes people are feeling overwhelmed by just providing clinical care. But I think it's an opportunity to facilitate research that improves patient outcomes, helps recruitment and retention of staff, and acts as part of that virtuous circle for everyone involved.
So, if it's okay, just tease out a few points you made there. One about COVID.
Yeah.
And the other about translational research. So, looking at the impact of COVID-19, the pandemic, on the research environment, last year, many in UKRD really stepped up to make sure that we as a national community supported urgent public health research, vaccine research. However, it did, not surprisingly, destabilise many research teams as workers had to go to the front line, as research priorities that were previously important were then perhaps reprioritised to deal with the pandemic. Is there a danger that COVID-19 will basically dismantle the current research priorities all over again should we have another wave fall upon us? What's your view of that?
I think there has been so much learning through the pandemic, but I'd start with what you said earlier. The UKRD and the research community stepped up as we have never seen before, certainly in all of my career, and both at a personal level for many people and also as a sort of community level, and really brought out extraordinary depths of what people gave. And I think that shows us what a strong workforce we have, but I know that some are feeling tired. And what we need to do is to harness all the best bits of that working, find a sort of more stable business as usual, allow time for recovery, and allow us to use this as an opportunity to retain the best ways of working. And some of that might mean thinking about what we do less of. We've got a very strong regulatory framework, and that's important to me as head of NIHR. But we've also had the opportunity to say, where do we have bureaucracy that we don't need? And the focus on reducing bureaucracy is also, well, how do we pull together, reduce duplication, so that we just ask ourselves, are we doing what's necessary? Because otherwise, we won't be able to move on so easily. So I think we look at the strengths of UKRD and its members. We harness them into a sort of collaborative way of working, which is my natural leadership. and say, how do we ask all of us to once again pull together? We will do everything we can to provide that resilience, so that we can weather what further challenges this pandemic brings. But I know that we have put so much into place, not just through the RRG programme, but through much more, and importantly through listening, so that we come out of this to be the sort of world-leading research ecosystem that I think we are and can be.
And Lucy, I think the UKRD community will really appreciate those words, not just to acknowledge the work they put in, but also the fact that they are an essential part of health, wealth and social care research and infrastructure going forward. You did also mention translational research, and I've often heard it said that perhaps if we were better at translating high quality research into the real world, we wouldn't need to do quite so much research that nobody bothered with. A bit controversial, but what's your view of that?
Well, I'm smiling because one of the reasons I'm sitting in this role is because I had that very question back in 2019 when I'd finished a number of trials and I thought, so what? What next? And so for researchers to understand that what next is to me really important. So what next into practice, into guidelines, into policy? And for me, what I've learned is that that's got to be the first thought, not the afterthought. That's got to be woven in to the design and the delivery, not just that final thing you do at the end of your grant. And so I think that also speaks to my call to all trusts to be research active, because my experience is that if trusts are research active, and why wouldn't you be? Every trust wants to improve outcomes for its patients. They also have a much greater buy-in to implementation. So for me, it's about saying, if you're there during research delivery, then the implementation seems much more obvious and it's relevant to your population. It doesn't really sit well that an NHS trust wouldn't do research but would just expect to implement it. It sits much better that this is part of business as usual within clinical care, and whether that's secondary care, primary care, community. So I think we can achieve much more from the implementation end by asking research to be woven into that business as usual, so that it becomes part of that translational circle, not just the final thing on a sort of left to right pipeline. I agree, and I think it's something all researchers should ask, but also all trusts should be asking themselves.
Thank you for that one, Lucy. Slightly cheeky question. Thanks for taking it quite so positively.
Important.
We're coming up towards the end of our time, Lucy. I've just got one more question before I sum up, if that's okay. And you talked about at the beginning your clinical role as a professor of obstetrics. What's your clinical role to you personally in terms of your values around research, health inequalities? Just give us a bit of an insight into that, please.
So for me as a researcher, I've grown up by having pregnant women at the heart of what I do. It's come very naturally in the pregnancy community, because in a clinical context, they've always been at the centre of what I do. And that's translated through into our research approach. It's one of the reasons why we have public and patient involvement in our research from when I started in the 90s. But also for me, working in Lambeth has shown me up front and close up what those health inequalities look like. And they're very clear. They're often quite complex. They're often quite multidimensional, and they may not be immediately obvious. But I certainly work in a very ethnically diverse and socio-demographically, in many senses, diverse. So that's why it's important to me now. As an obstetrician, we manage risk and that sort of complexity of risk. And I probably bring that through as well. But seeing that risk from many different perspectives, it might be from the woman's perspective, it might be from my healthcare professional perspective, or it might be from the system. And so I think that's woven into my thinking of risk from the NIHR perspective and as I lead NIHR.
Thank you, Lisa.
But I think I think it's been a very good career base, and I'm also passionate about sort of continuing in it. I'd also say to the UKRD community that I am doing visits out and about across the country, not just local to me in London. And I'm really learning about everything that I'm talking about by listening to those on the ground, which is an important part of how I lead.
So UKRD, we will be expecting the Professor Lucy Chappell tour coming around to your hometown, not just the big towns, but the coastal towns, steel towns, rural communities in the next few years. But I'm going to just summarise briefly, Lucy, and thank you on behalf of all of us. We've had an insight not just into your personal trip into the roles you've eventually ended up with, both clinical roles, academic roles, and now leadership roles. We've discussed health and social care as part of your portfolio, some of the priorities that we see nationally, and the need to make sure that not only do we tackle urgent public health research, but also the other important health inequalities research that are necessary for health and wealth creation in this country, along with life sciences research. And we've also talked about the fact that we must always have this underpinned by values, whether they're your personal values as clinicians or researchers, but also the values of all of us in the health and social care structure as part of NIHR and UKRD. So without further ado, I'd like to honestly and sincerely, Lucy, thank you very much for supporting us with our conference this year. I know you're extremely busy, but I think that will have given all of us not just hope and some enthusiasm and motivation, because as you've rightly said, we are a little bit tired, but it'll allow us to then plan our own priorities and give us that charge for the next year ahead. Hopefully we'll carry on that relationship with you as the years go on, and we'd welcome you to come back from time to time to update us on how you think things are going from your point of view nationally. But thank you very much, Lucy. Thank you very much indeed.